Good morning, everyone, and welcome back to our Introduction to the Use of Medicare Data for Research workshop. We're on the final day now. I am going to stop my screen share and let our speaker get his slides up. And our speaker for this morning is Nathan Shippey, who is actually the principal investigator of ResDAC. He normally presents a little earlier on in the workshop, but was not feeling well earlier this week. So we're very happy that he's back for today. He is also an associate professor in the Division of Health Policy and Management here at the University of Minnesota, has done lots of work. He's a sociologist that does lots of work on complexity in patient conditions with, patients with many chronic conditions, has done a lot of work in the Medicaid space as well. So we're very lucky to have him to talk about measuring comorbidities and chronic conditions in the administrative data. So I will turn it over to you.
All right, thank you. Yeah, it almost feels like I've been out sick for a while, so this is my first day back. I've got my inhaler in case I start coughing really bad or something like that. But so we're gonna talk about long-running conditions right now. I'm gonna bring up some slides. One thing I want to note as we're getting started is that this segment is going to serve a few different purposes, and so it's not really just about identifying chronic conditions, using particular algorithms or those kinds of things. There are a lot of lessons to take from how we use administrative claims data and the information that we can get out of them, and that kind of thing. And so that's one of the reasons why we still include this segment. As noted, I'm sure you're used to this now. The time for questions at the end. Please use the chat. We've found the chat feature to be really useful when it comes to kind of trying to answer questions on the fly, as well as keeping track of them when we get to the end. This needs to be updated just a little bit because we are trying a different format with a 3-day agenda, but we are starting with segment J today. So to begin with, comorbidity, we want to think about as this is something we often pay attention to through risk adjustment and other things. As a disease or condition, it's going to coexist with some primary index condition of interest. And so a lot of times when we're talking about chronic conditions or we're talking about other types of conditions we're trying to identify, it's not necessarily that this is something that is right core, the very beginning condition that we're looking at, but it is something that is very relevant to the treatment of that condition, how complicated that condition is to manage, risk adjusting, those kinds of things. We can measure this in a lot of different ways, but when we're talking about claims information, what we're doing is really using CMS diagnosis information in those claims data. We can mix those kind of the diagnosis information in different ways, but that's really where it comes from. And then we can kind of talk about why we would mix it in different ways, why we would create indices or scores or other ways to measure this. So again, keeping in mind that the diagnosis information is not coming from some external source, but rather we are using those same claims files that we would have access to for answering any other part of our question. So the information that we're getting is not coming from some outside quote unquote gold standard source. This is still coming from the claims data. And more to the point, the diagnoses for those conditions come in a particular form, primarily diagnosis codes. How are we going to use those is kind of an open question. In other words, there's no 100% right way, and therefore every choice we make is going to come with some trade-offs. Every choice we make is going to be some type of judgment call. So we could use them in a lot of different ways. One is we could take those diagnosis codes, use them to identify a specific comorbidity or comorbidities, and enter each of those into the model. And maybe we've got the statistical power to do that compared to a lot of other data sources where we might not. We could take a standard set of conditions. In other words, We may need to say, okay, well, we're not interested in everything under the sun, but that we know that there are certain things that are of, incredible importance for this particular condition or this particular treatment or this type of utilization that I'm looking at. So I'm going to take a standard set of those. We could try to group everything. We could say I'm interested in everything under the sun and try to group those somehow, or try to take those, put them in categories or some other scoring system or something that's going to use them. We could also create weights around them, which we're going to look at in a second as one of the more common ways that's been done historically, and at least some of the more well-known measures. And we can talk about why we would want to do that. Examples that we're going to start with really relate to things that people have typically kind of heard of before, maybe even used. The first is the Charlson Comorbidity Index. So if you've heard of Charlson, that's one of the very typical approaches that I've seen. We'll talk about whether that's a good fit or not, but it is one of the very common approaches that at least if you have a show of hands or something, people will often say, yes, I've at least heard of the Charlson, if not used it. The other one is the Elix-Hauser. And here we've got the Elix-Hauser score. We'll talk about whether that's appropriate or not in just a second. But these are just two we're going to start with. And if you're not familiar with these, I'll be introducing them a little bit. So to start with, the Charlson Comorbidity Index is a set of conditions that was originally abstracted from hospital charts, I believe in New York, used to predict one-year mortality. Charlson, if you have heard of it, if you have used it, it has kind of, I think, taken on this air of timelessness or something. It's just if people use the word Charlson over and over, it's as if it's been around forever, but it's actually only been around since the late 80s or 90s in practice. Mary Charlson and colleagues developed this, again, I think on a set of stays in New York. And it has since been then adapted for use with administrative data, which is, I think, one of the reasons why you're going to see it a lot in, anytime somebody's got some data and they've got the codes that they can use to adapt that set of conditions. This is one of the common approaches. So what you'll often see is you'll see the name Charlson and then dash and then somebody else's name who has adapted it for administrative data or EHR data or something else. So you might see Charlson-Romano. Or Charlson-Deo, or something like that. There are a number of different software macros you can find. There's just one here that's an example. And I just want to note that the Charlson score is not a count of conditions. It is not a count of conditions. Rather, each condition is assigned a score that is a weight. And we'll talk about what that weight is in a second, but keep in mind that if somebody has a particular condition, that condition is translated into a certain weight, which is an integer. It's just a number, but that it's going to be higher or lower. And then all of the conditions that they have, the weights for those conditions are added together. That's all it is. And so we'll talk about the process for getting there, but keep in mind that Charlson as an index is a true index in the sense that it is a sum of weights. And you can see the weights here in at least one example where metastatic solid tumor is a 6 and diabetes is a 1. Right? So how do we get to those? Again, we'll talk about that in a second because there's some really relevant pieces for that particular process of creating those weights. But keep in mind then that if a person were to have one or two of these, you would take the weights that are associated with them and add them together, and that would be their Charlson score. Yeah, let's talk about the weights here for now because we're going to switch over to Elix-Hauser. So these weights are assigned based on relative risk of an outcome. So originally that might be death, for instance, in the original Charlson, but if you were to adapt these, you could take these conditions, put them in a model, and get their relative risk of whatever outcome you're looking at. That is actually how the weights were originally created, and that's the process that anybody uses when you're adapting the Charlson. So if you're looking for a serious outcome like death, you'll see that some of these are associated very strongly and therefore have a higher weight, right? And so that's where the weights come from, is this relative risk translated into an integer, and that's where we get the weights to sum up for a score. So that's one approach to taking, one approach that people can take to score or otherwise account for comorbidity. Another way that people have done, which many people have heard, is the approach by Ann Elix-Hauser and colleagues, which is a little bit newer, but again, has been around a long time. And so you'll hear people talk about Elix-Hauser, especially if you're in the clinical outcome space or something like that. You've probably heard of this. So the Elix-Hauser is a set of 30 conditions, so a number more of conditions that were developed to predict length of stay, hospital charges, and in-hospital death. So again, keep in mind that these are originally developed primarily with an inpatient mindset and an inpatient set of outcomes. Again, these can be adapted to other outcomes. They can be calibrated and adapted for other outcomes, but that's just where these originals come from. I always think it's actually useful to look at the original articles. That's what I have my clinical outcomes students do when we're looking through, is actually check out the original article. These articles do exist. They're not super far in the past. And it's useful. And one of the things you'll learn when you look at the original article is that Ann Elix-Hauser and colleagues suggested that we don't use their set of conditions as an index or as a score. In other words, not indexing them together. But that's what most people actually do. So what most people actually do is they use this set of conditions not as a list of things that have been shown to be predictive of these outcomes and therefore, they're potentially important, but rather they take this set of outcomes, score them, by which I mean they count the conditions and then add them up into a score, and they call it an index. Again, that's against the advice of Elix-Hauser herself and her colleagues. There are a couple of software macros here, but so keep in mind that the way that most people use the Elix-Hauser index is, or the Elix-Hauser set of conditions, is as an unweighted index or a count of conditions. So slightly different from the Charlson. Now, Gagne et al. Is an interesting case, and I'm going to bring this up here because this is something I've seen used in clinical practice and other places. Sometimes I've seen EHRs actually calculate, people have had this calculated automatically for different reasons in their EHRs. Gagne is a combined score. So Gagne takes conditions that are in Charlson and Romano, or not in Charlson and Romano, but in Elix-Hauser, and combines them together. So some that are not in Charlson Romano, some that are not in Elix-Hauser, and therefore there's overlap, but not perfect overlap. And of course, Elix-Hauser is a longer list. So you take those all together, and then you score it. You create a score in the way that Charlson created a score. That is a weight based on outcome again. And so if you have a relative risk that's higher, the condition will be weighted more heavily and so on. So again, this is the set of conditions comes from both the Charlson and the Elix-Hauser separately, but they are kind of combined in the approach of the Charlson, which is the weights are created based on relative risk and then added together. What Gagne et al. Found was that this actually predicted mortality better than either the Elix-Hauser or the Charlson alone. But here's the interesting thing. Maybe use the chat. Does anybody notice anything strange about this figure? Just give you a second to look at it. Just grapple with. This is a comorbidity score. Right. Erica looks like, yeah. Juliet, yes. Right. So we have less than zero comorbidity, right? So this is where measures and how they are useful to us is kind of an open theoretical question. These are legitimate scores based on the process. So let's go think back to the process. Again, the score is based on the sum of weights. That means somehow there are some weights that are less than zero? Well, that means that in the models that these conditions were put into, somehow they were associated with a score, a risk less than zero. So we might call those protective factors or something if we were modeling them. That's probably not the case, though. And this is where the creation of these things from the administrative data, it's important to think back to all of the things that you've been hearing about in terms of strengths and weaknesses in the process of the creation of these data. Think about data generating mechanisms rather than just kind of immediately assuming that there's something with the modeling. One of the conditions that's associated with negative risk is hypertension. If somebody just had hypertension, they would actually have a -1 score. Why would that be? There could be a few different things. The most plain example is that this is in the MedPAR, that is in the hospitalized Medicare population. Most, maybe close to all people could be diagnosable with hypertension. It's a very, very, very common condition diagnosed in this population. And so what we could think about is, what does it mean then if somebody is not diagnosed with hypertension? What it could mean is that that person does not have good access to care. So if you want to flip it a little bit, instead of saying that having hypertension is a protective factor, you could say that not being diagnosed with hypertension in this population, this may not be true if you were to take this approach elsewhere, but in this population, not being diagnosed with hypertension may mean that actually that person may not be getting great access to care. They may have other conditions that are much more serious, and therefore their hypertension is not being listed as a diagnosis. There could be a few different ways that that plays out, but one thing that it probably doesn't mean is that having hypertension means negative comorbidity or something like that, right? So this is just an important thing to think about. Now, if we were including this as a covariate in this population, maybe that's okay. Maybe we're okay with that, because what we're not trying to do is map comorbidity. We're trying to use comorbidity as a covariate. And therefore, these kinds of artifacts, representative as they are of, as proxies maybe of access to care or other things, maybe it's okay. But it's important for us to realize the implications of what happens when we make these choices with administrative data. It's also a really good illustration of why we might want to not automatically assume that utilization equals need in any population when you're looking at administrative claims. So those are just some considerations. The other interesting case here is that if you go way back to when we talked about the Charlson, if you look at the scores here, notice right at the top we have AIDS as one of the two top weighted conditions, meaning it was associated with a lot of risk in the original Charlson. That's under that population in that scoring. What's interesting is that actually in the Gagne et al., the other condition other than hypertension that is associated with a negative weight is, I believe, HIV/AIDS. Now, again, we can only speculate as to how that comes out as a negative score, but if a person is only listed as having HIV/AIDS in this population, in this draw, from, I think this is 2019 MedPAR, we can make a few guesses. So one thing might be a survivor effect, where the people who, of this group, which is primarily age-defined, is in Medicare, is still alive in Medicare, that there's some type of survivorship bias, where the people who are still around in the data who have HIV/AIDS diagnosed may have really good access to care, maybe on heart treatment or other long-term treatments for HIV/AIDS, those kinds of things. So this may be a select set of the population that has been diagnosed with that particular set of, with those particular set of diagnoses. So there could be again a selection or some other proxy pattern that we're seeing, rather than actually saying that, for instance, the statement that HIV/AIDS would be somehow protective in comorbidity or something like that, right? So it's just important to think about the patterns that we see are probably very much shaped by data generating mechanisms that are much bigger than the diagnosis of any one condition. And those include things like access to care, what other serious conditions are in a person's profile, those kinds of things. All right, so more generally then, we've kind of talked about how might we use comorbidity, but if we think more broadly, maybe we need to define a population based on a chronic disease, right, or some other reason for identifying chronic conditions. And we're using chronic conditions here because, again, these are conditions that people have for a long time, usually require treatment over a long period, and therefore they're likely to show up with some kind of a standard regularity, not standard, but some regularity in the claims data. That may or may not be true. It's true to differing degrees with various kinds of conditions, but with chronic conditions, it just provides us with some at least expectation that we should see some kind of regular care happening, or at least care over time happening in the claims data that would generate the claims with the diagnosis codes that we would use to identify these conditions. So you could extend this in different ways, and again with different caveats, to lots of different conditions. But we want to identify people with some set of conditions or some condition. We may want to, again, define a population. We may want to do various things. But we need to think about how. How would we do this in the first place? Which diagnosis code should we use? Do we use anything that falls in a particular category? What procedure codes might we use? Right, so we've talked about procedure codes or HCPCS codes. Are any of those relevant on their own or together with the diagnosis codes? Which administrative data file should we use? Right, should we just stick with inpatient files? Right, so if the Charleston originally or the Elix Hauser originally, if those were originally for inpatient settings, should we assume that we can just use inpatient files? If so, are we okay with losing people's conditions if they were never admitted? So we just need to make choices. And if we include all of our administrative claims files, are we going to get the representation of the conditions that we want with the proper specificity? What positions? So by position, we mean where in the claim form. Usually if something is of primary interest, it should show up in, hopefully one of those first position or second position on the claim form. Do we only include those because any other information is just kind of contextual or less reliable? Not sure, right? At least it's a judgment call that we need to make. And lastly, we can think about, well, how would we judge among all these different, as we make these different choices, how do we even tell if we're making the right choice? This is just to kind of put up, for some EPI 101 kind of approaches, but we're going to be talking about sensitivity and specificity and positive predictive values. So just kind of putting this up here for reference. All right, so using these diagnosis and procedure codes, how might we approach this? So if we go back and think about, we have a sample of diagnosis codes here, but there are a number of them. Now I'm still stuck in probably ICD-9 world. I probably remember more of the codes there for certain things than I do better than ICD-10. So the list in my head is probably very old-fashioned. But if you looked in ICD-10, you could find usually a large number of specific codes that could actually be used to represent a particular condition of interest, right? So the code that exists, if you're looking at a particular list of codes, that one code, if you choose that, that's leaving out any time that somebody, a coding and billing department or someplace else, use some slightly different code to represent that condition, right? So we probably need a set of conditions, and we need to figure out what is the proper set of conditions. Again, where do we find those? Just the first position? Anywhere on the claim? Remember, think about some of the forms that you saw in the claims data source and processing segment, right? There are a lot of positions for diagnosis codes on a claim form. Do we just take the first one, maybe the first couple? Do we literally, are we okay with going through say 25 positions on a claim form, and if the condition shows up, or sorry, if the condition code shows up any of those places, are we okay with that? With the diagnosis code showing up anywhere? Do we include any procedure codes? In other words, are we worried that the diagnosis codes might not be there sometime and it's just represented by a procedure code instead? And again, which files do we use, right? As you've seen, we've got a number of different files, which of course each have their own file segments. Which ones do we use? Where do we draw this information from? So I'm going to walk you through some very early work that was part of, so Marshall McBean, if you look down at the author list down at the very bottom, Marshall McBean was the first PI of ResDAC and was doing some of this work back in the 90s with a team that has, it mirrors very much what some of the very common approaches and common algorithms are today that we still use. So I'm just going to walk you through some of the basis for that. This doesn't mean that this is the only way to do it. And actually, as a matter of fact, like our policy at ResDAC is not to be overly prescriptive on most things. We'll tell you if something is really, really off base or something like that, obviously, if somebody asks. But at the same time, when we show you something, this is the only way. Rather, this is a common way. And it's very relevant for some of our file segments, as I'll get to in a second. So this is just to introduce this. But this is from Hebert et al. In the American Journal of Medical Quality. And other people have done similar work that found somewhat similar approaches. So it's I would say, broadly kind of reproducible over time. But again, if you take a specific look, you'll find that a lot of these are actually they're judgment calls based on some specific uses of the data for validation. Big slide, but what Hebert et al. Were doing is trying to answer a lot of the questions that I've just raised in terms of which codes, which files, what position of the file, what position of the code on the claim form, some of those kinds of things. So to set this up, rather than worrying about the numbers, what I want you to pay attention to is the very far left column. And they are kind of in a cascading pattern setting algorithms, which are just sets of rules for, is a condition met by this algorithm. So the first set is one or more claims with a diabetes diagnosis. They were looking at diabetes specifically. So one or more claims, that means we're not requiring two claims to be absolutely sure. We're only requiring one claim. And you'll see down a little past midway that they did also check algorithms that required having two or more claims. So they did require more claims in those. Now they took specific files. So when they say short stay hospital, our files have changed their names over time, sometimes multiple times. That's the inpatient file, basically. So if you start from the very top, there on the left column, one or more claims with diabetes diagnosis, so just one or more claims in what would be the inpatient file. And then they're looking at two different rows for that being either only the first listed diagnosis or any diagnosis. In other words, any position on that claim form. And that's the algorithm. When we say an algorithm, we're just it's a set of rules for whether a flag is triggered as being positive. Does it appear that many times in that way? And what they were doing then to compare these is looking at the sensitivity and specificity, and eventually I'll show you positive predictive value for kind of each of these sets of rules. Then what they did is, so those were for individual files. So then what they did is they realized, well, any individual file, if you notice, the sensitivity is pretty terrible on these. So then what they did is they combined files. So rather than just looking in the inpatient file, if you note the first algorithm here is one short stay hospital, so one inpatient, one skilled nursing, or one home health agency, claim. So that's one claim in any of those three files. Or two or more hospital outpatient claims. So two or more claims in a hospital outpatient file, or two or more that's called a physician supplier claims. That would be called the carrier file now. So or two or more carrier claims with a diagnosis code. So this is kind of, you know, two additional or statements on top of the inpatient file, skilled nursing, and so on. So it could appear in either one inpatient, skilled nursing, and so on, or two outpatient or carrier. I'll say that again. One claim in the inpatient or skilled nursing or home health, or it could be two claims in the hospital outpatient or the carrier file. Now you could wonder, well, why would we allow why would we allow one claim in the inpatient file versus two in the outpatient? It's often that we're kind of relying on the diagnostic certainty of the inpatient space more to say, okay, if somebody had a stay for this, what we're saying is, okay, if somebody had a stay where this was identified, an inpatient stay where this was identified, we're taking that as one claim is sufficient. But if it's in the hospital outpatient space, maybe an outpatient emergency department visit where they were never admitted, maybe a hospital office visit, or what they call the physician supplier claims, or what's now called the carrier file, representing all kinds of provider claims. We're requiring two of those, and that could be for a lot of reasons, but I would just suggest the idea that any kind of diagnostic testing that happens in the outpatient space or with a provider outside of a hospital setting could trigger this algorithm, because a diagnosis code could be connected to a test, but we don't know if that test is positive. So anytime that you have a diagnostic test for diabetes, and let's say that you're found to be pre-diabetic, you could show up as having the diagnosis code for diabetes in the claims, despite being listed as pre-diabetic as the result of this test that you had. And so at the very least, patient and clinic space, they're requiring at least two of those claims. So the one inpatient, one skilled nursing, or one home health versus two outpatient or carrier, that kind of number and file type combination is has become a very common way of identifying conditions, at least in Medicare, and I will repeat, at least in Medicare. What I found in Medicaid, that is often undersensitive, but in Medicare, where enrollment is a little more regular and so on, this has become a very common approach. And I'll show you just how common in just a second. But so you can note that the sensitivity comes up a lot when you start including multiple files. The specificity is excellent, and the positive predictive value is also good. And so this is kind of their basis for finding. And I would say that first algorithm, the algorithm number one, is really the one that they kind of found to be their kind of go-to approach, and that's the one that has really been again kind of built into a lot of design since then. So, and this next piece is very relevantly tied to that. So I'm going to give you some background on the CCW flags here. So just note that we are still, we'll come back to this work by Hebert et al. In a second. All right, so chronic conditions in the Chronic Condition Warehouse, or CCW, you can go to ccwdata.org. They list all of the condition categories, and I should say categories because these are broad categories. This is not a specific listing of diabetes with only two diagnosis codes or something. It's usually going to be several diagnosis codes in the general category of diabetes. So that may or may not be useful for you. You may need more specificity than that. but often it's a useful start at the very least. These are included as one segment of or a set of segments in the master beneficiary summary file. So when you looked at those, the MBSF segment that we gave you, one of those segments is the chronic condition segment, and the other is the other chronic and potentially disabling condition segment. So we've got indicators for the presence of several conditions. They going back as a fairly rectangular, simple file indicating does that person have that condition for that, based on the data, going back to 1999 for most people, in the same way for, basically anything for the master beneficiary summary file. And it's got standard definitions, criteria for reference periods, diagnoses, and I'll show you these definitions in a second, and their definitions line up with the algorithms from Hebert et al. Fairly well. Originally, there was a smaller set of conditions, including AMI, Alzheimer's, a separate one for a slightly broader category of ADRD, cataract, chronic kidney disease, and so on. Certain types of cancer. Then some additional chronic conditions were added, and now what we have is a newer version of this set of conditions in a newer version of this file. So if you see a set that is not 27 but is now 30, this is why originally when I say 27 on the slide introducing this, it's now fairly recently been amended to this 30 chronic conditions file. And so if you're getting data now, you'll probably see 30 conditions instead of 27. So it's been a slight update. There have been some slight algorithm changes and things like that. Example of changes would be moving from AFib only to AFib and flutter, with some slight changes in the diagnosis codes and so on. Cancer, certain cancers, Parkinson's disease, pneumonia, some other things have been added to get up to this 30 conditions. And again, this is part of the master beneficiary summary file. The other segment in the master beneficiary summary file is really useful if you're interested in mental health, as well as behavioral health and certain genetic and other things that have been added, sensory issues, those kinds of things. So there have been a lot of things added. Now, what I would suggest is that the exact validity of this many conditions being added in, you'll want to look at each condition on its own as to whether you trust that being a good, valid representation of your condition of interest. The one example I would give is obesity. Obesity may or may not be something that is always diagnosed regularly. At the very least, its reliability may be in some question, even if you trust its validity in certain circumstances. So again, I would just note that, and also note that a number of these are things like alcohol use disorder, tobacco use, and mental and behavioral health. These are things where the diagnosis itself may be surrounded by a little bit more uncertainty, certainly may be underdiagnosed more often than some other types of conditions. And so just, keep in mind that the diagnostic process is part of the data creation process. And so what we see in the data stems from that. So again, these are two segments, the chronic condition segment and then this other chronic and disabling condition segment, are both segments of the master beneficiary summary file. And here's the tie that I wanted to make back to Hebert et al. With those algorithms. If you'll note, if you go to ccwdata.org and look at their definitions, you can download these in a PDF. It's actually a really interesting resource. You can download a PDF file, and that's actually what I clipped this from what I remember at least. Is that if you look at the far left column, you'll see that there will be a particular condition category, an algorithm either for asthma or AFib or BPH. But again, this is for any of their conditions. They have these. They'll give you the reference period. So remember back to Hebert et al. They were looking at one 1 year versus 2 years was one of the things that they were testing. Most of these are going to be 1 year. They'll show you the ICD-9 and the ICD-10 codes, because obviously if you're going back, 2015 and before, you'll need to know the ICD-9 codes. But you've got those, and if you'll note, most of the time, those are diagnostic codes. So we mentioned, do we use procedure codes? Not often. They do show up, but at least as you can see here, most of these don't. And then the last thing I wanted to draw your attention to is the far right column, and you'll see how this kind of lines up very closely with the algorithm set of rules that I was listing from Hebert et al. So that is, what number of claims and from what type of, what claim file. So for asthma, for instance, it follows very closely with the one claim from either the inpatient, skilled nursing, or home health, or 2 hospital, outpatient, or carrier claims with any of those diagnosis codes. Right, so that is pretty much verbatim the set of rules that we take from the Hebert et al. Article. And again, it still remains a pretty common approach, at least with Medicare data. The last thing I would just note is that, we mentioned position on the claim. Note that in the condition codes, the diagnosis codes for both ICD-9 and ICD-10, you can see that at least for asthma, they're saying any position on the claim. So they're not just requiring first position or something like that. But for AFib, they do. Right, and so it does differ depending on the algorithm, but again, this kind of solves a lot of but it answers in its own way a lot of the questions that we were raising in terms of, what codes do we use, what files do we use, how many years of data, where on the claim should it be, any of those kinds of things. And then sometimes you'll have exclusions like for BPH there as well. So this is the kind of algorithmic set that is used for those CCW chronic condition and other disabling condition segments in the master beneficiary summary file. And I can't stress enough, they are already available in the MBSF. So unlike any of the other approaches that we're going to look at in just a second, these already exist for you in the Medicare data, and are, if I can editorialize a little bit, are lower cost because they're part of the master beneficiary summary file, which is relatively affordable as data files go. So if you're looking to kind of define a population and some of those kinds of things, I would at least take a hard look at the segments in the MBSF based on these. All right, some other, we're just going to kind of list some other approaches to note that that's not the only way. So despite those being available for you, they may not be doing what you want. They may not be good enough for risk adjustment for you, for instance, those kinds of things. So some other examples that I would just throw out here as things that I've used. There's work from under HCUP with ARC, the Healthcare Cost and Utilization Project with ARC. They have their software that you might be able to, we've certainly adapted with Medicaid files in the past. Excuse me. But we've got that available. And I would just note that the clinical classification software is kind of a bucketing approach, where it kind of just takes everything and puts it into buckets. And it has different levels of granularity and complexity. So you can take a single level, which is kind of big, broad buckets that I haven't found to be as useful, but they're simpler to use. And then there's the multi-level, which gets down into a little more specific. Now that can be paired with the CCI, so the CCS can be paired with the chronic condition indicator. And what that does is it flags if a condition is chronic. So if you use the two together, you can kind of get a number of chronic conditions based on a bucketing of like basically everything that we can find. So that's just something to think about. One thing to keep in mind, of course, is that HCUP is primarily using, with the NIS and the KID and those kinds of data sources. A lot of that is especially useful for inpatient, some emergency department use. But I would say we have definitely applied it to a general population, so not just a hospitalized population as well. Another example is the VEP 100, which is the verifiable expensive predictive conditions. So you can identify conditions, and then you can kind of come up with lists like this that have been kind of validated for you by other authors. That's another approach. And it may include the things that are of interest to you. Various cancers, depression. What's interesting here is that obviously there are depression codes for when depression's in remission. This would exclude those kinds of things. But again, you want to just kind of look at each of these approaches and say, is it drawing out the kind of specificity that I want, or not? And to kind of draw some big comparisons, just to understand what each of these kind of look like from the standpoint of maybe a descriptive or measurement properties aspect. Keeping in mind that the Charlson, going back there, is a set of conditions, but they're translated into a weighted index. Elix-Hauser, as we mentioned, is a set of conditions. They're not weighted, it's just a condition. And so you could create a score, but that score is just a count, which means it's technically an unweighted index. And if you want to think about it, not weighting is a kind of weighting. It just means that everything is weighted the same, right? So the presence of one condition, no matter how serious that condition, is just another integer to add, another integer increase compared to any other condition, no matter how serious that other condition might be. So it doesn't weight based on the seriousness of conditions or anything like that, which is true of any time we take a count of conditions, right? We're not weighting any of them particularly heavily. We have Gagne et al., right? There's a big, broad number of conditions with the overlap between Charlson and Elix-Hauser. Again, weighted based on the Charlson approach. We have the CCW flags we've mentioned. Those are just condition categories, and it's okay to use some and not others. Those are not created as some kind of a validated list where you have to include everything. You have other things like CMS uses hierarchical condition categories for various reasons. In risk adjustment, you've got 70 categories there. There have been a lot of changes to that over time, but that may be administratively useful. It may be something you want to pay attention to. You have the VEP 100, which of course is essentially a count of 100 conditions out of a set list. We have the clinical classification software that I mentioned from HCUP. The single level, as I mentioned, is a smaller kind of number of things where they have 285 diagnosis based and then 231 procedure based. The multi-level breaks down with even more levels of specificity in that. So it can get pretty big and complex, but that may be the complexity you need. We have diagnosis related groups used for inpatient specific risk adjustment by CMS, where we've got a number of different things in the creation of that. But you've got, say, 467 categories that you might pull from there. And again, those are inpatient specific, so they include things like newborn and so on, which may be less likely to show up in the Medicare data. And then we got just an example of one. There are a number of these. There are also, proprietary systems. And I'm just listing the ACG system. I believe it's from Johns Hopkins because I've used it in one project before. Again, it's just an example of a proprietary approach where there may be cost reductions for academic researchers or something like that, but it is a proprietary system where things are broken out into diagnosis clusters, diagnostic groups, and then I would just call back to the CMS HCCs or hierarchical condition categories. Similar to that, the ACG system has both categories as well as you can get a score, some type of risk score. So similarly, the hierarchical condition categories, you can get the categories, those 70 categories, as well as a score. So there are a lot of different ways of mixing this information based on kind of preset lists of conditions and so on. So there's a lot of possible ways of doing that. Each of these is created for a particular purpose, right? So Charlson originally created for, hospital risk adjustment for risk of death, whereas hierarchical condition categories and DRGs are used by CMS for a different type of risk adjustment. So just keep in mind that all these are kind of created with different purposes. They're going to have different conditions included or not included. They're going to be specific on things that you want or not less specific on things that you want, right? And an example here that I'm just going to throw out there is, and we need to update some of these, I think, because we're still kind of pulling from ICD-9 examples, but is the specificity for use with mental health disorders. Again, this is just something that I know that I've used because I spent a fair amount of time in the mental behavioral health space. But if you look at hierarchical condition categories, at least 2014 version, you had category 52 was both major depressive disorder and bipolar disorder in one category. So it's kind of like a mood disorders category, not necessarily super useful if you're trying to do studies related to mental health. But it also included delusional disorders. So again, just not as granular as what I would probably want. They did have a separate one for schizophrenic and schizoaffective disorders, but nothing for anxiety. Right? So that's one way of saying, well, are those HCC categories, are those what I want? But maybe that's a high enough level that it's actually useful for you. The CCW, other chronic and potentially disabling conditions, remember that segment's in the MBSF. This one's useful because it's changed a little bit over time, but you've got depressive disorders. It importantly includes this dysthymia, which is kind of this longer, more constant lower level depression, which is really common and is excluded by a lot of other categorical approaches, as well as depressive adjustment reactions, which are not often included in other approaches. And so there's a lot of different kind of, pieces of fitting in. Well, we have a category for depression. Well, which diagnosis codes does that include? It differs quite a bit from approach to approach. In this case, depressive disorders has its own category, and that category covers a lot of the things that I, as a mental health researcher, would probably say, okay, I need those things included. It also has bipolar disorders separately, which is different from hierarchical condition categories. And it has a category for anxiety disorders, right? So it starts breaking things out in ways that are a little more useful. But if I were to then compare the clinical classification software approach, which is a third approach, if I took the single level, remember that there can be single level versus multi-level in the CCS, the clinical classification software from HCUP. The single level is more similar to what you see up at the hierarchical condition categories. So things grouped together, probably a little less granular than what I would want as a mental health researcher. But if you take it to the multi-level, it becomes much more complex, but it's also more useful to me in a way that's similar to the chronic condition data warehouse categories in the MBSF. So all of these, there's going to be some overlap in terms of how they use the information and mix it and package it for our use. But that's just an example of 3 different approaches and what kind of granularity and information you get. So I guess the takeaways that I would suggest are, first of all, consider the purpose and also remember the source of each of these approaches. So even if you can download a software macro and make it run, we need to think about why we're doing what we're doing. So are we doing this just for risk adjustment? Are we trying to identify people with multiple chronic conditions? Are we trying to identify a specific diagnosis or set of diagnoses? What is that approach that you're using? What was it originally designed for? We can repurpose them, but we need to do that thoughtfully. Again, think back to the Gagne example where we had negative comorbidity, for instance. We can do those kinds of things, but we just want to be aware that we're doing it. Does it matter whether we can interpret, again, that Gagne with negative comorbidity? Well, if I'm trying to interpret negative comorbidity, that doesn't make much sense. But if I'm including it just as a risk adjustment and I'm actually okay with some of those things showing negative because they pick up that some of the proxy of access or whatever else is going on, and I'm okay with that because it improves my prediction or adjustment, maybe that's fine. Again, we just want to kind of think of what's the purpose, why were they created, and how are we using them? Are we interested in their relationship to the index condition? So are we looking at comorbidities mainly because they're related to, diabetes, for instance? Or are we just trying to get counts? Are we just trying to count things? What were they validated on originally? And are we using them for a slightly different outcome? If so, do we need to recalibrate? What population, also I should add, were they developed in, and are we using them in a different population? Are they going to have the kind of granularity in the population that we're looking at? I would also just note again that the chronic condition data warehouse categories, those algorithms we looked at that are similar to Hebert et al. And so on, those are in the master beneficiary summary file already. Those are segments there. The work is done. And so if you're trying to look for kind of a general look, or you don't necessarily have specific reasons for why those don't work for you, just keep in mind that that work is done, and it's again a relatively affordable as data files go. Maybe that's enough for you. The reason I say that is because, and this is my kind of broader takeaway, is that all of these different approaches, whether we're talking about the VEP 100, whether we're talking about the HCUP approach, the clinical classification software, whether we're talking about the CCW flags, whether we're talking about hierarchical condition categories, any of that, they're not pulling from some outside source. They may be adding some constraints. So for instance, when we add weights, we're adding information in. We're helping to constrain some of those pathways to get it to make it useful. But there's no magical outside new information, new data that we're pulling from. All of these are created based on the information that's in the claims files. And pretty much all of them are actually mostly drawing from the diagnosis codes that are available in the claims files. So in other words, these are all drawing from the same well. And so we just want to kind of think about, if we're using a particular approach, yes, we could use some other approach, and they would probably do a different job in risk adjustment or whatever else. Or if we're trying to identify our population, they're going to do slightly different things, but they are all drawing from that same kind of set of information that underlies all of this, which are the diagnosis codes, primarily the diagnosis codes in the claims files. So just keep in mind that they're all drawing from that same well.